Welcome to Getting Better with Dr. Adam. Dr. Adam Silverstein is a clinical psychologist who has been working in the field since 1993. With a broad range of clinical experience, including state psychiatric hospitals, adolescent residential treatment with a trauma focus, the Department of Corrections, and in the addiction treatment arena. Adam is currently in private practice and serves as a clinical consultant and supervisor for a number of treatment centers. This podcast is for general information and entertainment purposes only. This should not be considered treatment advice, nor is it a substitute for an individual treatment plan. If you have questions or concerns about your individual situation, it is strongly recommended you consult a licensed professional to talk about things that are specific to you. If there is an emergency, it is strongly recommended you seek treatment at your nearest emergency room.
I just had a really interesting conversation with Dr. Paul Thornburg, who works in the correctional system. So in psychotherapy, one of the things that's critical to look at is this thing called therapeutic alliance, right? Which is this relationship between therapist and patient or client? Is it helpful? Is it working? Is there a good connection? But in addition to the good connection, is there some sense that there are agreed upon goals and a sense that we're working on this together, this journey together to achieve the patient goals? And imagine how hard that is to look at in general, but what would it be like to look at that in a setting like the Department of Corrections, which is, I worked there myself for years, and which is an atmosphere that is so tense, strained, and it feels like you can feel it. It's palpable. It's palpable out there to feel the tensions in the atmosphere. How do you bring therapeutic alliance and look at this discussion of therapeutic alliance in a setting like a prison? So please enjoy this conversation with Dr. Paul Thornburg, who has a lot to say and a lot of ideas about contributions to the field of correctional psychology. Good morning. I am excited to be speaking with Dr. Paul Thornburg. I just want to give a little bit of background, but first say hello. Hello, Paul Thornburg.
Hello, Dr. Adam Silverstein.
So nice to have you here. I just want to share with people my interest in speaking to Dr. Paul Thornburg. I started the infancy of my career after I got licensed. I started working in corrections. And I just want to say what that means. I worked in a prison setting, from maximum security to a more minimum setting. I saw so much of what it's like to be in the universe of corrections. And wow, if for anybody who's listening, who's a therapist or wants to become a therapist or works in recovery in any capacity, I cannot tell you what an impactful experience that was for me on so many levels, eye-opening, profound. And when I started working in corrections, the culture was, at least where I was, and probably all across the United States and in jails, the culture was very much, it's time to really focus on bringing in mental health and mental health care and medical care and dental care and all sorts of treatments to make them available to this vulnerable population. And the atmosphere was shifting from a mode of correction, right, to this word rehabilitation and an obligation to help those struggling, help the incarcerated to heal. And so I was there, and it was really, really early on in this process, in this infancy stage where I was. And all of a sudden, there became this massive presence of both medical doctors and clinical psychologists and social workers and therapists. And all of us were like, we're here to help. And in the beginning, so much of that looked like stabilization, because there were really, really acutely sick individuals, in my experience, many people who were formerly serviced in state hospitals that were closing, prison became a new center for mental health, unfortunately. But a lot of the job was about detection of chronic mental illness and then providing the right stability and security and treatments, both medication and offering psychotherapeutic support to help stabilize. So I really, and I just want to add, and I know I'm going on a little bit on this, but I learned so much about the world, right? About the diversity of the world. I was open to a world that I probably never would have stumbled upon. And it taught me, if I'm going to reach people, right, especially there, I always tell my students that I work with, and I learned this in prison, lose your NPR voice. Whatever phony psychologist voice I had to lose it quickly, because I would get eaten up alive there if I presented even remotely inauthentic. And, this sort of direct way to speak and how to reach people who struggled in that way was such a challenge. And just the whole universe of that system in and of itself, I learned so much, and I'm grateful for my experience. So that being said, that's my introduction. I thought it would be cool to invite Dr. Thornburg, who has himself years and years of experience working in the correctional atmosphere, and also has written and studies what therapy, the sort of the future of therapy, and an awareness of what therapy is in that setting, and areas of future interest of how to improve, not just in terms of presence and stabilization, but also improvement in quality of care and how to look at that. And I would invite this discussion. It's a focus on corrections, but in general, it's a great way of looking at the field as a whole, right? Are we doing a good job? What does it even mean to do the job? So with that, welcome, Dr. Thornburg, and why don't you tell us a little bit about yourself and what your interests are?
That was a great introduction. And
thanks. I really flowed out of me.
No, that was fantastic. And I think a lot of the things you shared, I have the exact same sentiments. And there's so much to say. But I think what I want to do is focus on my interest in studying the effectiveness of therapy in correctional settings. And what I found is that the Therapeutic Alliance is one of the most thoroughly studied aspects of the therapeutic process, and has been broken down by a lot of the leading scholars like Bruce Wampold, Scott Miller, Michael Lambert. And what they found is that the Therapeutic Alliance is one of the most robust predictors of outcome in psychotherapy.
Okay, so simplify it a little bit. So when we say Therapeutic Alliance as a metric or an outcome of psychotherapy, what is that even? What are you referring to?
Well, I wouldn't call it an outcome of psychotherapy, but it's a contributor to the outcome, meaning, is the client benefiting? Is the client improving, getting better from therapy? And you're right, we need to define the Therapeutic Alliance, because a lot of times we just associate it with the therapeutic relationship. And do the therapist and client like each other? Are they getting along well? And that's an important part of the Therapeutic Alliance. But as it's conceptualized in the literature, the alliance is quite a bit more. In addition to, and they refer to it as the affective bond or the connection, right, between the therapist and client. But in addition to that, there's two other components that are really important. One of them is the degree of collaboration between the dyad, between the therapist and client, on the tasks of therapy. So what is the client going to do, and what are the therapist and client going to do together to try to help the client reach their goals? And to what degree are they collaborating, instead of, the therapist just sort of dispensing interventions from on high to a passive recipient of therapy, right?
So in that space of collaboration, meaning I may have more knowledge about, for example, what an anxiety disorder is or what addiction is, I could be a lecturer and transmit that information or relay that information to the individual. You be quiet, I'll talk, which probably happens in my sessions a lot, right? And just listen and absorb what I'm saying. And that is not that would not represent a collaboration of joint goals.
Exactly. So to step back, there's one other component to the alliance I want to talk about, but to step back even further, the alliance, as it's pretty widely agreed upon by researchers and scholars, it's really, you can think of it as a reflection of the degree to which the therapeutic dyad is actively engaged in the collaborative process of trying to help solve the client's problems. So you can think of the alliance as a measure of collaborative engagement, right? Which when we do what you're, in jest referring to about talking too much and talking at our clients, that's not necessarily, or probably not at all, reflecting engagement, especially on the client's part, right?
Can I just do a sidebar of my
Sure.
own in my own world? I do this group that's really important to me. It's called a goals group, and it's not cheesy, right? It sounds like, oh, what's your goals? And I used to go into centers, and and there could be in Los Angeles here, there could be probably at any given time like 1,000 different groups going on. And I would ask this question, like, it's really important to me. I'm the group facilitator, and everybody's got an individual therapist. And I'd say, what are you working on? And the answer would be, I have no idea.
Mm-hmm.
I have no idea what I'm working on. So the whole focus of the group, right, for me is, what do you want to work on? Right?
I don't think that's cheesy at all. I think that's absolutely
meaning that I know just the name goals, meaning like it sounds like, it doesn't sound like, oh, what's your goal? But it sounds so elementary and obvious, but it was so not obvious because the response rate of what am I working on was like I was asking the most like it was like a crazy complex problem. I have no idea what I'm working on. None. And so the focus of that experience is bringing it back to, what is it that you want to work on? Truly. Now, don't just say sobriety, and don't just say anxiety. What do you mean? What do you want? Because it may not be the diagnosis, right? You may want other things. So
absolutely.
So anyhow, that was my sidebar. Continue, Dr. Thornburg.
No, I love it. This is a great discussion because a couple of things. One, the focus on, or the agreement on the goals of therapy is different than the collaboration on the tasks, right? And that's the third component. So to break it down, there's three components to the alliance. One is collaboration. Well, excuse me. The first one is the therapeutic bond, right? The second would be collaboration on tasks. But the third one is agreement on the goals of therapy. And I love how you said that this sounds so elementary, but the research shows that clients and therapists, whether they're in corrections or not, are often not on the same page regarding the goals of therapy. And let me ask you, Dr. Adam, whose goals do you think matter more? The client's goals for their own lives, or the therapist's goals for what they think the client's life should be like?
So ultimately, from a buy-in standpoint, I need to know where client-patient is at, because I can pontificate all I want. I have a lot of ideas about what someone needs, right? But at the end of the day, right, if I'm not aligned and I don't have a buy-in, it's going nowhere. So I have to meet somebody where they're at, right, really, because if I don't, I'm in trouble, right? Because I'm going to be a lecturer and I'm not going to be a collaborator.
Exactly. And you use the word buy-in, right?
Yes.
And that's a critical part of it is, and you also use the word alignment, or aligned. And those words are really good descriptors of a solid therapeutic alliance.
Dr. Thornburg, I also want to say that
Yeah.
I also kind of like, I kind of like was led by the witness a little bit. So I knew that would be the right answer. So I kind of like, how am I going to mess that up? But I kind of know we're going here, it was an easy feed, but I actually do believe what I'm saying. I really do believe what I'm saying, because otherwise it becomes a dynamic of lecturer, even if someone is like in recovery, someone is in the throes of denial with the gravity of their addiction, right? I'm still going to have to meet somebody where they're at, even though I know intuitively, like, hey, IV heroin is probably not a great idea for your goals, right? If they're not with me, they're not with me, and I have to start at some basic beginning.
Absolutely. And as elementary as that sounds, I think we often fail to align with our clients' goals for their lives at our own peril, at the risk of our own ineffectiveness, right? So I love how you put that. Well said.
So I take this information, and I know the field. This is an aspect of understanding benefit of therapy, right? We're not talking about method. We're not talking about schools of thought. We're not talking theory, and we're not talking about best practices. We're talking about how to assess the value of this experience based on this relationship, right? So, in any, and this could be applied to any form of therapy, whether it's in a correctional setting or not. What made you interested in the world of corrections and how this plays out there?
I really stumbled into corrections not very intentionally. There was a gig available. I had some time to do it. So I gave it a shot, right? Without really having any expectations or even a strong desire to work in corrections. But right from the start, I was just totally enthralled with what's going on in corrections and the possibility for therapeutic work with especially incarcerated men. It is just like you were describing at the beginning of our discussion. It's such a unique world, and it's really hard for anybody who hasn't been in corrections to really understand what it's like within the prison walls. But it's a whole world unto itself.
I don't know about you, Paul. The first time I walked a yard, time I did that, you pass the gate and you walk a long football field down there. I thought my first thought was like, I see people, I'm like, I'm dead. I am dead. I was so scared. And fast forward, years later after being there, I was so comfortable. But just the and you can feel it, like it's palpable there. The atmosphere, the tensions, and so here you are. You come in and we're talking about therapies, and I remember thinking to myself, what on earth is therapy here? Like, what does that even mean? I'm hearing voices. I got to stabilize. I'm in a manic episode. I got to stabilize this guy. I got to help him stabilize. Or I'm depressed and I'm suicidal. And I get that sort of like, jump in there and help. But how does this therapeutic alliance idea of co-collaboration and agreed upon goals, right?
Yeah.
What is it that you're experiencing? What do people want? How do you even assess? What do you want, right? Like, what do you want if you're there for life? What do you want? How do you even look at this?
Well, that's the fundamental question, because just like people outside of prison, prisoners are a heterogeneous population with variable problems, right? So that's the first task is establishing an alliance, establishing the rapport and the therapeutic relationship, but then also establishing what the client's goals are. And I like how you referred earlier to something about, treating a diagnosis versus treating a person with problems. And I think that's where we get into trouble, is if we focus too much on just treating a diagnosis, because that may or may not be what the client's primary concerns are, right?
Mm-hmm.
So, yeah, you have to talk to the individual. And I just, another little sidebar, there's so many different offshoots of conversations we can have. This is a really rich discussion, but I like how you talked earlier about inmates just seeing right through the pretension uh, and condescension that sometimes we can bring to the table. Inmates are master bullshit detectors, and they have to be to survive in a prison setting, right? So if we come at them with an air of phoniness, oh, they're gonna call you out right away on that, which is a good thing, because then it's a chance to elevate the relationship to a more authentic, genuine aspect. So I think I forgot your original questions. I got sidetracked on the sidebar, but you're
I was talking about what therapy looks like in that
yeah.
setting, and how it was confusing. It was confusing in a sea of instability, right? True mental health crisis, as well as this landscape of corruption. And when I say corruption, I mean everybody's fighting for survival, right? It's a dangerous place. And what does it even mean? What is a problem in that atmosphere? How do I even get to it? It's like chronically tense. Right. So what does it even mean to find an agreed upon goal? And I remember just my experience was, if you're listening to this and you're thinking about going to work with adolescents, people with substance use issues, or in corrections, you will be lied to. Right? You will be lied to, and that is just part of the game. That's part of the atmosphere. So is it an offense to me that I'm going to be lied to, or that I could possibly be, my services maybe have an ulterior motive, right? For whatever reason, I can experience that and say, that's cool. I get it. You have an ulterior motive. Is there anything you want to work on anyways? Right? So How do I get past the ulterior motive aspects of, hey, I'm doing this because it looks good for my case and I'm appealing. Hey, I'm doing this for a safety reason because if I'm in this mental health program, then I'm here. Yes, it may be based on something that it is predominantly not somebody truly seeking it from a sincere, 100% sincere place. If I can get past that, right, then perhaps I can ask the question of the individual I'm treating, right? And I notice how I moved away from the word inmate, right? I can ask the question of the individual I'm treating, what is it that you care about in this current environment, right? And so what I'm asking of you is what have you found to be if we're not going to base it strictly on a medical model of, you have an anxiety disorder, let's reduce your anxiety. You have suicidal ideation, let's reduce suicidal ideation. Let's eliminate it. Not that that's not important. Then what would be and that could be the goal, but what would be other aspects of agreed upon goals, right, that build therapeutic alliance?
Yeah, I mean, again, it comes back to the individual person, right? And if you're talking to a lifer, somebody say who's new to prison, facing a life sentence, and they're asking themselves, I can't do life, or how can I do this? Maybe that's the challenge. Maybe they want to find a way to just cope with a life sentence. Maybe their family is starting to leave them, right? Abandon them. Maybe that's something that they're struggling with, and they need someone to talk to. One of the things you hear people in prison say a lot is that they don't feel like there's anyone that they can talk to because everybody wants something from them, or there's always just layers, right, of hidden agendas. And so they sometimes just need to be able to talk to someone about what they're going through and be able to do so honestly, in a way that they don't have to worry about self-preservation. There's a real hyper-masculinity in male prisons, right?
Mm-hmm.
Where uh, they're very dangerous places. So to avoid looking vulnerable and being a target of victimization, inmates will put up this false facade of, um, I've got it all together. I'm strong. I don't have any problems. In fact, that's one of the challenges with getting them to engage in mental health treatment sometimes, is that if other inmates see them engaging in mental health services, they might be perceived as weak
Mm-hmm.
and vulnerable, and be more susceptible to victimization. So that's another
So even if I have
challenge
this
and issue.
terrible, terrible experience of life in prison, right? The idea of just having as just even having a place to let my guard down even a little, right? That could
Mm-hmm.
be, forget about everything else. Maybe that's at a minimum, that's what somebody says, I want that, right?
Right.
And and you're already looking into how can I find a agreed upon goal, and very different than someone who's got a 5-year or 10-year sentence, right? Who may
Mm-hmm.
be thinking
Right.
about what am I going to do to rebuild on the outside when I do get
Mm-hmm.
out of here, and how am I going to make it in here without collecting more, without getting in fights and collecting more time,
Right.
right? So there may be different ideas. So what's your sense in terms of building this therapeutic alliance, right? What are the variables in this specific setting that could impact the effectiveness of therapeutic alliance from both a inmate standpoint and a provider standpoint?
Well, I think again we get back to basics. Um, Correctional settings have a certain culture. I'm talking about the staff that work there. There's a culture. I mean, let's back up even more. Prisons were not designed to be environments in which therapy is provided, right?
Mm-hmm.
Prisons are designed to punish and to ensure safety and security for people on the outside. And that's been the predominant, it's been the purpose of prisons up until pretty recently, where there's now an emphasis as well on rehabilitation. So, in that context, it's important to recognize that therapists are influenced by the greater correctional culture, which is one, again, that focuses on punishment and a hierarchical relationship. There's a huge power differential that needs to be addressed in order to provide effective treatment. Because inmates come into that relationship already, many of them, already sort of conditioned to see the therapist as just another member of the correctional staff, almost as something akin to a prison guard. And so the therapist needs to overcome a lot of those built-in barriers at the beginning. And how to do that, I think we get back to the basics of therapy. Empathy, right? Empathy is a really, obviously, in addition to the alliance, therapist empathy is one of the most well-founded predictors of effective treatment. But in prison settings, empathy is often in very short supply, and it's really easy for the therapist to have a lot of negative countertransference reactions to inmates. It could be based on their crime, what the inmate has done to other people
Mm-hmm.
for which they got arrested. You mentioned something before that's really essential, and that's about inmate manipulation and malingering. When a therapist starts in a prison setting, day one of their orientation is going to consist of all the different ways in which inmates manipulate, malinger, lie, and there's such a huge emphasis on setting firm boundaries that you can take that too far.
Mm-hmm.
So that you set your firm boundary, and the inmate isn't going to manipulate you. But if you're too harsh and too severe in doing that, well, you're also not going to be therapeutically effective with that person. So I'd say it gets back to basics. Genuine, the Rogerian principles of genuineness, positive regard. It's not easy to do in a prison setting,
No.
but you have to do it in order to be effective.
Well, I hear you. And when somebody voluntarily comes into my private practice and they really want to work on something, it's, I don't have to bring into the experience the same degree of, hey, watch out, right?
Right.
You could
Right.
be, there's something, you can be exploited. Me, the provider, you can be exploited if you are too generous, right? And you don't if you're too generous, if you do anything to break a rule, you will be preyed upon, right? And
Right.
and it's not fair to say that's not true, because there is truth to that. It does happen.
Absolutely.
So the challenge here is, how do you hold space for both firmness, boundaries, awareness of what that would look like, right? Protect safety, right? Safety. How do you do all those things which are critical, right? Because bad shit happens there, right? Like, people get hurt.
Yeah.
So how do you?
This is the fundamental challenge of providing mental health treatment in prison settings, is balancing the safety and security needs of the institutional reality, and balancing those with engaging in effective therapeutic principles. There's a body of literature establishing essential therapeutic principles, and those same principles apply in correctional settings. But you have to balance them with the other. So how do you do it? That's the fundamental challenge. And I'd say for myself, you establish professional boundaries, and I don't do anything that would get me in trouble. I'll go to the ends of the earth therapeutically to help someone, but I won't do something that's against the rules, and I let the inmates know I wouldn't do that as well. And it also boils down to what are they willing to do, right? So I think, and this gets to an important point, is establishing the therapeutic alliance before jumping in to providing interventions, right? What does he want to accomplish? What's the main problem that he wants to address in therapy? And then we talk about avenues and tasks to help him to accomplish that. And this is going to involve things that he's going to do for himself. And I can be something of a guide, mentor, and help him to realize the changes that maybe he wants to make, but I can't accomplish those things for him.
It's interesting. In the world that's outside of corrections, it reminds me of this idea of, some people call it the therapeutic frame, or even just the concept of informed consent, right? We talk about what this is and what this isn't, right? I am not, what this is and what this isn't. And we can't hang out. We're not friends, right? This is, what does this relationship look like? What can you expect from me, right? And I'm going to be consistent with that. I'm not going to veer. And in a similar way, what you're talking about is setting the tone from the onset, not just in terms of goals, but what this is and what this isn't. I'm not going to be able to get you. There are no special favors. I can't break rules on your behalf. I'm going to make that very clear. And that's abundantly clear. And I'm also going to talk about that which we could work on together. And I'm not going to work harder than you either, right? Like, I'm not going to, what is it that you want, right? I'm not going to force you to want anything. I'll definitely share ideas, and whatever you want to bring, I'm going to meet you there, and I will work within the frame that I can to do that. So that would repair a therapeutic alliance. But I'm curious, in terms of your studies, does the atmosphere, and which it was created for that with good reason, does the atmosphere of correction piece, right, not the rehabilitation piece, the safety, the danger, all those things, does it influence the therapeutic alliance, not in terms of the presentation of the symptoms of the patient, right, in this case, but in terms of the effectiveness of the provider.
Absolutely. The correctional culture in which correctional treatment is situated has a tremendous impact on all aspects of mental health treatment. And I think they need to be addressed up front and acknowledged with the person that you're treating. You had mentioned addressing those things up front. This is what I can do, and this is what I cannot do. And they hear so much of the time, this is what I can't do for you, right? So they get that when you say that, but you also then, I think, need to distinguish yourself from all the other correctional treatment providers and staff that they've interacted with by saying, but here's what I can do, and here's what I'd like to do. So you let them know that you're in their corner, and there's nothing more that you would like than to work with them to help them realize whatever goals they have for themselves. And emphasize that, because I think that's a part that is often missing. We can't talk about working in a correctional setting without addressing the issue of burnout, provider burnout. Correctional providers are at extremely high risk of burnout, meaning, sort of a sense of depersonalization and emotional detachment. And it gets manifested in disinterest and even a hostile, and I hate to say it, but it's not that uncommon for even providers to have a hostile disposition towards the person that they're providing treatment. And so that ends up impacting that client's, the recipient's perspective going forward, and lowering their expectations for what an effective treatment provider can be. So addressing this issue of burnout is really important. And a really interesting finding in the research is that obviously burnout is associated with poor alliances and poor treatment outcomes. But conversely, effectiveness and the drive to improve your mastery of your craft is associated as a protective factor against burnout.
Wow.
So this is a really critical part of the equation, is seeing where you are in that burnout risk category. Are you striving to improve your effectiveness as a therapist? And if that's your focus, it's a bit of an antidote to burnout. And I this applies to every setting, right?
Totally.
But it's more amplified in a correctional setting where the threats to the therapeutic alliance are even more severe because of the degree of tension and manipulation and malingering.
I'll say that it's just like everybody's doing time. So, and everybody's doing time in that setting, right? People are sort of, that's where they work. They're collecting their retirements and their benefits and so forth, and they're doing time.
Exactly.
And so how do you want to do time is a fundamental question, not just in a correctional setting, but in life, right? Like,
yes, I love it.
You can phone it in and just sort of just coast and and I get that, and just like wait till it's all done and then you're done and just be like, or you could be like, I want to really invest in this thing. And I'm reflecting on my time there, and it takes courage. And this is the real truth for me. It takes a lot of courage to care there. And I really want to preface this by saying that we're in the infancy stages, and I shouldn't speak for you, but in terms of the studies and the investigation that you endeavored to pursue in terms of finding this information relative to other settings, I would imagine corrections in terms of therapeutic alliance has less information and less study than other places, right?
Right, absolutely. It's a closed environment where it's very difficult to get permission to engage in primary research.
And that plus it's a relatively new phenomenon in terms of
Also,
it's a relatively new phenomenon. So
right.
in terms of the struggle is it actually takes courage to care because the dominant culture is one of safety and punishment, right? So that's the atmosphere. So to be someone who leans this way, there's also a social pressure from the environment that, hey, you are potentially doing something that is dangerous and on some level, not explicitly dangerous, not like, hey, I'm bringing someone drugs or a weapon, but on the road, implicitly on the road to something that could compromise. And that's hard. It's hard to be a provider, right? When what you're talking about may not be celebrated, right? It may be something that is suspicious, right? It's suspicious behavior.
Yes, there are very real risks and threats. So it does require courage. Correctional clinicians work under the constant threat of being accused of overfamiliarity with inmates. So, and this, you might get accused of overfamiliarity without doing anything that jeopardizes the safety and security of the institution, but just, in the eyes of some, just treating inmates as human beings, and get back to Rogerian principles of really honoring the individual and privileging the client's voice in therapy. And that does rub some people the wrong way.
Right.
So you need to be mindful of who you're communicating to about how you work there. But you also want to be an agent of change. So you need to be a force because the system is changing. In the time I've been there 16 years, and I've seen the culture change, and there is more and more of an emphasis on rehabilitation and therapeutic, basic therapeutic principles, which include the Alliance. So it is a difficult place to work.
It is, but also it's not for everyone. That's for sure. But I'm interested. I like the fact that it takes a long time for a culture to change, a long time, and I think that what I take out of this and how do I want to approach life in general is I don't want to go to extremes. I want to be able to say that it makes a lot of sense to hold two positions at one time. It is an unsafe environment. It does safety is a factor. If I'm on the line as a correctional officer, holy shit, meaning if things could erupt, right? I have to be vigilant, hyper vigilant so often. I mean, friends of mine who were officers, they still walk into rooms and they stand at the doorways,
at the edge of the
right. Not everywhere they go, right. Everywhere they go, they're alert in that way, and most people aren't, right. But they've been trained to be. So I have to be aware of that, but I also have to be aware of bringing a certain type of humanity and agreed upon goals and all the things. And I think that future directions is where all this goes, right. And what is the future? And what you're talking about is probably, the direction that it will increase as we go into rehabilitation. And I wonder, just based on your perspective, I'll ask you this question. In your experience, in terms of, quote unquote, the most difficult, right? And people think like, oh my gosh, are these people even able to get any help? Let's base it on your therapeutic alliance model. Do you think people can get helped? Do you think the difficult can be open to help in that way?
I mean, the simple answer is yes, but of course it's a little more complicated because just like in treatment on the outside, you're not going to have 100% success rate. And in prison, it's going to be perhaps, depending on what the goal is, substantially less than that, right? But you don't know who's going to benefit and who's not going to at the outset. So you need to, I think, see each individual as having the potential for growth or benefit, and then you give it your all, and some are going to benefit, some may not, but you don't know who they are. So I think you need to look at each individual as having that potential.
I love this. I can go on for a long time on this.
Oh, I know. Me too.
I just want to say that I remember, in early days of speaking to you, there's I was sharing before we started how you would bring an atmosphere of presence. You were so invested in the idea that you would ask the individuals you were working with, the patients, right? The clients, you would say to them, you were sharing, you'd say, where are you? Here. What time is it now? And that sort of atmosphere that you brought to such a difficult experience that you were describing, so powerful. And in usual circumstances, this is kind of funny. I ask people who come on and speak to me about how could somebody reach out to you if they need help? I don't want anybody to go to prison to reach out to you. Right. So that would be odd, right? To say, if you want to work with Dr. Thornburg, please go to prison. So that's strange. I don't think that's a good move. But I do say, if people have interest in the discussion or the expansion of ideas about Therapeutic Alliance, where do you want to give an email so if anybody of our listeners have questions?
Sure. You can email me at PG for Paul Gregory, PG Thornburg, THORNBURG @yahoo.com.
Thank you so much, Dr. Paul Thornburg. Such an interesting conversation.
Thank you.
Thank you for your
Adam.
good work, thoughtfulness, and I'd love to connect with you again. All right.
Yeah. Looking forward to it. Take care, Dr. Silverstein.
You too. Bye-bye.
All right. Bye.
This podcast is for general information and entertainment purposes only. This should not be considered treatment advice, nor is it a substitute for an individual treatment plan. If you have questions or concerns about your individual situation, it is strongly recommended you consult a licensed professional to talk about things that are specific to you. If there's an emergency, it is strongly recommended you seek treatment at your nearest emergency room.